Sesamoid bones, like the patella, act as mechanical pulleys. They develop within tendons in response to mechanical stress. Evolutionarily, they optimize force across species. They are crucial for complex movement.
The study of sesamoid bones traces back to Galen. He likened them to seeds of Sesamum indicum. Structurally, they are embedded within tendons.
A critical distinction must be maintained between these two bone types. Sesamoids protect host tendons from friction and wear. Accessory ossicles are non-functional and derive from a failure to fuse. Sesamoid bones originate within tendons. They form synovial joints to enhance leverage. They absorb massive weight-bearing loads and are present in all humans. Accessory ossicles are unfused bones. They arise from secondary ossification centers. Bound by synchondrosis, they often lack mechanical function. Type A sesamoids are situated adjacent to joint articulations. They form true synovial joints with hyaline cartilage. The patella is a primary representative. Type B sesamoids develop where tendons angle around bony prominences. They are separated by a protective bursa. The os peroneum is the classic configuration.
Tendons develop specialized nodules. They provide strength and compressive elasticity. This occurs as the tendon winds beneath the malleolus, predisposing it to eventual sesamoid formation.
Early skeletal development involves two distinct populations of cells. SOX9+, Sex+ cells form superstructures and sesamoids. Progenitors condense at the cartilage margins. Adjacent cells form skeletal superstructures, while distant cells become sesamoid bones. Pools form skeletal superstructures, such as the deltoid tuberosity, adjacent to the bone. TGF-beta and FGF regulate this phase, occurring independently of muscle load.
BMP signaling drives sesamoid growth. BMP2 is universal, specific differentiation. Sesamoids lack a true periosteal membrane. This limits vascularization and fracture healing.
Lacking this membrane, sesamoid bones are entirely dependent on renders sesamoids susceptible to a vascular necrosic under condition biological timeline required for fracture union. Ossification depends on mechanical loading. Fetal nodules are more numerous than adult ones. This indicates that strain selects which regress, reflecting genetic and environmental influences. Located at the base of the great toe, it associates with the flexor brevis tendon. It is present in all populations. Ossification begins earlier in females than in males. Maturation finishes by early adolescence.
The helical lateral sesamoid is associated with the flexor hallucis brevis tendon. It is present in nearly 112 in males. It completes by early adolescence.
At the first MCP joint of the hand, these sesamoid bones of the South Indian population, ossification begins earlier in females than in males and reaches full completion by age 16. The sesamoid bone at the thumb's first IP joint associates with the flexor pollicis longus. It has a 40 onset is 10 for females. It completes by age 16. Located at the fifth MCP joint, this sesamoid associates with the flexor digiti minimi brevis. Ossification begins earlier in females than in males, completing by age 16. Let's locate the sesamoid at the fourth MCP joint. It associates with the tendons of the fourth digit. Prevalence is 0% in South Indian populations. As many as 42 sesamoid bones can develop in a single individual. Most people have 5 in each hand. The vascular supply is provided by the palmar metacarpal arteries. In the foot, 2 sesamoid bones are found at the first metatarsal head. Absence of these bones is rare. Bony fusion to the metatarsal is also seen.
Sesamoid bones are highly variable, reflecting their capacity to adapt to diverse demands. The ancestral tetrapod-limbed lacked ossified sesamoids. These structures evolved independently, multiple times across lineages.
The patella's evolution shows deep plasticity. In mammals and birds, it acts as a lever, but in most marsupials, it is absent. Tendons attach directly to the tibia as adaptable structural design. Bony patellae evolved 4 to 6 times, once in monotremes like the platypus, again in the extinct multituberculates, and up to 3 times in therian mammals.
Most marsupials lack a bony kneecap, possessing a soft pad instead. This structure shows great histological diversity, yet some species possess fully ossified patellae.
In the red panda, the pseudothumb originally evolved to assist with climbing and arboreal locomotion. It was later exapted to help grasp and strip nutritious bamboo stalks. Cotton rats have a special bone to grip small branches. Elephants possess 6th toes to distribute their massive weight. These bones remain unossified for years. The patella is mechanical. It increases the moment arm of the knee. This reduces required quadriceps force, helping to support weight and propel the body.
In the first trimester, the patella first appears. This fibrous band undergoes chondrification, By week 23, it resembles its adult shape. Ossification continues into adolescence.
The patella increases the knee's moment arm. At 45 degrees, leverage peaks with a 30% boost. In deep flexion, this contribution falls. The tendon wraps directly in the groove. As the knee flexes, the moment arm decreases, dropping linearly from full extension to 60 degrees. Leverage peaks near 45 degrees before dropping. Scale, not sex, determines moment arm length. Near full extension, the patella transmits tensile forces. As flexion increases, bending forces generate compression. This generates compressive forces across the joint. To prevent joint wear, the contact area between the patella and femoral trochlea increases as the knee flexes, distributing substantial rising forces which reach peak levels during deep squats.
The posterolateral knee can host two sesamoid bones. These are the fibula and the cyanella. They can cause pain or mimic pathology.
The fibula is a small sesamoid bone. It is found behind the lateral femoral condyle. It can cause painful vascular and nerve syndromes. This bone complicates total knee arthroplasty. Asia shows the highest fibula prevalence. Rates are moderate in Oceania. Europe and Africa show the lowest. It is tied to ligament thickening. This affects knee interpretation. The cyanella is a rare sesamoid bone. It is found within the popliteus tendon. Its prevalence is incredibly low, appearing in less than 1% of cases.
Unlike the fibula, the cyanella is more common in females. It accounts for over 63% of documences. A giant cyanella can severe lateral knee pain, miming air.
The human pisiform is a small, pea-shaped carpal bone. It articulates with the palmar surface of the triquetrum. But is it a true carpal, or is it just a sesamoid bone? The pisiform is classified as a sesamoid bone. It lacks a periosteum membrane. It is the last carpal bone to ossify. It acts as a spacer, increasing leverage. Conversely, evolutionary models suggest the pisiform is a true carpal bone. These models propose that it shifted ulnarly and palmarly. Later models view it as a pulley within the FCU. Pisiform evolution shows carpal row displacement. This element shifts from the central row. Polydactyly vestiges appear as a post-minimus digit. Humans have a short pisiform bone. This is due to losing a growth plate. Genetic studies show this. Hox genes regulate this change. It matches the human condition. It evolved after Australopithecus. The helical sesamoid complex consists of two small bones. They are embedded within the flexor hallucis brevis tendon. The tibial sesamoid is larger and more vulnerable to stress. In hallux valgus, the first metatarsal drifts medially. The sesamoids are held by the transverse ligament. The tibial sesamoid rotates on its side. This causes localized weight-bearing and cartilage erosion. The lateral sesamoid is displaced. The medial sesamoid rotates. This leads to erosion and leads to secondary osteoarthritis. Clinicians must differentiate pain between several pathologies.
While localized sesamoiditis is typically an overuse injury, bilateral inflammation should is clinical suspicion for systemic diseases like or seronegative rheumatoid arthritis.
Reiter's disease is an autoimmune arthritis. It presents with a classic clinical triad. The earliest manifestation is enthesitis. It typically affects the Achilles tendon. Management begins with conservative measures like orthotics or immobilization. If these fail, surgical intervention may be considered. However, complete
tibial sesamoidectomy weakens medial structures. This leads to hallux valgus. Fibular sesamoidectomy causes hallux varus. Complete removal results in a cock-up deformity.
Excising the tibial sesamoid weakens the medial insertion. This allows the lateral muscles to pull the toe. This creates a progressive hallux valgus deformity.
Excising the fibular sesamoid disrupts the insertion of the adductor hallucis and the lateral head of the F. This allows the medial head to pull the toe medially, leading to a progressive hallux varus deformity.
To minimize complications, we use the Walter-Mueller axial view. This assesses coronal plane rotation. The Yildirim classification measures medial sesamoid subluxation.
Yildirim grade 0. Medial sesamoid is entirely medial to the crista. No rotational correction required.
The medial cestin 50% of its width is displaced ocrista. Look for mild pronation and early capsule attenuation. Manage with balancing or distal osteotomies. Grade 2 shows over 50% displacement. Notice the moderate pronation and flattened facet. Shaft or proximal osteotomies are required. This is necessary to restore proper alignment.
This video reviews Yildirim grade 3. The medial sesamoid is completely displaced lateral to the crista. This severe metatarsal pronation typically requires a lapidus. This corrects rotation and restores joint congruity.
Apparent lateral subluxation is a three-dimensional deformity. Clinicians perform targeted osteotomies. This restores proper anatomical alignment. It recenters the sesamoids. This preserves long-term function.
This website makes learning so easy. I found all my resources here.